equipment cost differences and also Medicare reimbursement differences. Therefore, I wouldn't want to be flipped in answering. I would also say that I recently saw data that suggests that kyphoplasty long-term compares favorably with vertebral augmentation in terms of overall cost, whereas there is a higher upfront cost that mitigates over time. Where I saw that, I can't remember, and I don't remember the specific reference. There is existing literature in Vertos 2, et cetera, that does compare in euros the cost of people managed with vertebroplasty versus conservative therapy, and while the cost was a little higher, again, over time, that certainly mitigates. These are thoughts from my head rather than specific answers to your questions. So if other subject matter experts could answer the CAC number, please feel free to press, I think it's *1.
So there is nothing no literature that talks about improvement in pain versus how well they're doing their activities of daily living, not just for stroke, just in general?
No, I think there's extensive literature about that in all the trials, but we wouldn't compare it. I thought you were asking specifically against the 6-point MRS. I only use the modified Rankin score as it relates to stroke, but that may be a limitation of my own practice.
Yes, it doesn't have to be just with MRS. Any type of, just talking about, is there any difference in the motor activity, getting back to ADLs, that type of thing between the two procedures?
So, I mean, there are numerous, all the studies study quality of life and things of that sort. I want to be careful about answering with respect to motor skills. And in the comparisons of these different procedures, vertebroplasty versus the actual comparator, which is conservative therapy, or kyphoplasty against the actual comparator. So we're removing the studies that looked against sham because that's not something that one would do in real-life practice. There's tremendous advantages in terms of return to function, quality of life, et cetera. In the equivocal trials against sham, one did not see that type of sustained difference, but as I said, one can't do sham in the clinical arena. There were some small trials or some trials of vertebroplasty versus kyphoplasty, but I don't want to speak to them with respect to how those folks did with respect to quality of life. In general, I would say that, to get back to an earlier point, when people would think of vertebroplasty or kyphoplasty, they would think of them both as having significant impact on improvement of pain and functional outcomes versus the traditional comparators, which would be what one could get in clinical medicine, which is conservative therapy. So both would be expected to compare favorably to conservative therapy. I wouldn't want to comment on vertebroplasty versus kyphoplasty. Does that answer your question?
Yeah, thank you very much.
Pleasure.
And Dr. Parlap, Dr. Beal looks like he wants to weigh in on this also, operator. If Dr. Beal, if you have something specific to this question, but otherwise we're going to move on. Operator, if you could open his line.
Largest registry, U.S. registry, 792 patients. It had pain improvement from a 8.7 to a 2 in terms of numerical rating score, and pursuant to your question, had the Roland Morris disability improvement from a 21 to a 7. And this is mean functional improvement. So hopefully, I'd like to touch on the cost of the procedures. Typically, a kyphoplasty kit is roughly $1,500 more than a vertebroplasty kit. And this is a rough statement. I realize that. There's two papers, one by Ong and Osteoporosis International in 2012 that showed it takes 2 years, but the medical management of vertebroplasty, because it's less effective in terms of pain reduction, is then at the 2-year crossover, kyphoplasty becomes more effective, cost-effective than vertebroplasty. And the other article is by Ansgar Lang, published in Spine in 2014, and that delta is at 4 years, where the overlap between kyphoplasty becomes more cost-effective than vertebroplasty. So it's quality of treatment effect.
Thank you, Dr. Gill. Okay, I think at this point we'll move on to the next question. Doesn't appear to anybody else being in the queue. The next one is directed again at, I think, advocates of augmentation. The topic question, before we get to the discussion question, or the overarching question is number 10. If at least intermediate confidence, in other words, greater than or equal to 3, is noted in questions 1 or 5, and just to remind people that they were just the general questions of whether you think kyphoplasty or vertebroplasty, there's enough published evidence that you think you're confident, at least at a level of 3, that it improves clinical outcome. So if you're in that group, how confident are you that there is adequate evidence each of the following non-surgical management intervals be attempted without success before augmentation? 0 days, 1 to 7, 1 to 3, 3 to 6, or greater than 6 weeks. And again, when you get to the voting, each of these you would give a number to. But for the purpose of this discussion, we want to get a feel for where things stand as far as those who believe in augmentation. How long should the non-surgical management be tried? I think for Medicare coverage now, I think most of the MACs have something on the order of 6 to 12 weeks. But it does seem like that the trend of the main research, which I cited in the introduction, seems to be focusing more and more on the acute fracture, which should be less than 3 weeks. So I know that there's difference of opinion on this, and also there's some thought that maybe there's different indications for different time periods. But so the discussion question is, for each interval above that receives intermediate confidence, in other words, greater than or equal to 3, so if 1 or more was less than that, we don't necessarily, that's no confidence for that interval. We don't really need to discuss that. But those that 1 or more that had a rating of 3 or more, please discuss clinical parameters that would impact length of non-surgical management. Dr. Hirsch, you want to kick this off again?
Yeah, I think actually it's a really great question. So, when we started doing this so many years ago, this seemed like such a dangerous procedure, and we all had this notion that fractures will heal. Therefore, in our own guidelines, we pushed for the notion of failing conservative therapy. And in fact, in my clinical practice, I offer conservative therapy not infrequently in discussions with patients and consultations in advance. I think that Greg makes an important point, and it's that with some of the publications, there's been a trend towards talking about sort of the hyperacute phase. And while it's not published, and I think we should be careful in terms of talking about results, there has been effort to differentiate acute from chronic fractures, and there is an ongoing trial looking at chronic fractures, in this case vertebroplasty versus sham. What I would say is that Dr. John Barr and colleagues, and I was one of the colleagues, tried to tackle this question a number of years ago of what is a failure of conservative therapy? Is it defined by time? Is it defined by severity of the symptoms? Does it mean someone who's been admitted to the hospital and you can't get out of the hospital? And this was an effort to get at this sticky idea of what does it mean to fail conservative therapy, as there is no standardized definition of conservative therapy. And